What we're going to be doing is we're going to be doing intubation, somebody who has potential cervical spine injury, right? And oftentimes when you get to the scene, either BLS or the firefighters, they may elect to put a C-collar on the patient, right? Because they're worried about potential cervical injury, right? So those patients who have cervical spine injury, we cannot place them in ear to the sternal notch position. Remember how I was showing you with like, they had like this, right? Actually, come over here, right? If I was like, imagine this is roses, right? Stay like this one. This is roses, and you're going to snip the roses without moving. Yeah, okay, just moving exactly. So ear to the sternal notch, and the way we do it, we do padding, right? If we did this for him and he has a cervical spine injury, right, we now potentially cause damage or harm to him, right? If he had like a C3, C4 injury, right, we don't want to have him be paralyzed, right, or impair his, phrenic and then diaphragm, right? Phrenic nerve and then the diaphragm, the respiratory functions, right? So what we're going to do is we're going to show you how to intubate somebody with the position where they're lying flat. You cannot align the oral axis, laryngeal axis, and the pharyngeal axis in the mouth to get optimal view. You cannot. So this is why I'm going to use a bougie, right? You must have a bougie. Usually when they advocate this procedure, they say what you want to have is video laryngoscopy. So like remember in the similar with the video laryngoscope, and then the other one was a bougie. So since we don't have video, we're going to use direct visualization. So this is going to be DL, called direct laryngoscopy, right? You're going to get a bougie, and then this is going to be employed. This is called the Code tip, right? The Code tip. So this tip, right? And I know some of the videos or some of the instructors will say, well, you want to feel the rings, right? Truly speaking, the best landmark to know that you're in the right place, you're going to get hold up. This is not going to advance because you're going to hit right main stem, it's going to stop. If I was in the esophagus, this will going to go down all the way, right? So hold up is the best marker. And then we're going to lace the tube over it, right? So here, this is straight to cuff, but we're actually not going to use the stylet. We're going to basically use this to railroad it over, kind of, right? One trick that you want to do is this, right? So there was a, can you bring me that mannequin cutout over there? So you see how the bevel of the tube, right, is pointed sideways, right? So when I'm here, right, the tendency you see of this bevel is to get caught right there when I'm putting it in. So if this were to occur and this bevel is to get caught, you're gonna rotate the tube, right, counterclockwise, like this. So the bevel goes up, and then you'll be able to advance. Everybody see that? So if you're feeling hold like it's not going through, right, pull back, rotate, and then it's gonna advance forward, right? This is what usually happens, right? So hopefully that was clear, right? How we're gonna do this procedure is as follows, right? We're gonna have one person who is gonna be my partner, and they're gonna perform what's called the ear muff technique. What this means is that once we open the collar, and we need to open it so that the jaw becomes mobile, the mandible becomes mobile, the person who is gonna be the partner, they're going to grab the ears, and their job is essentially not to allow the head to lift off the stretcher or wherever the patient is laying on the floor, right? Your job is to hold the ears so the head does not move up. Everybody follow? All right, so this is what we're gonna do. So who's gonna be my partner? James, you come this way, so you got room, right? So we're gonna say in the initial phase, right, we already did our assessment, we determined the patient meets the criteria for intubation, right, which are the indications: failure to protect or maintain airway, failure to ventilate or oxygenate, and then the expected clinical course is to decline, right? Some examples would be like maybe they have airway burns, so we decided to intubate them early, right? And we suspect cervical spine injury. So what I'm going to do is I'm going to say, James, take over C-spine with ear muff technique, and I'm going to open the collar. So go ahead, put your hands this way, come this way. Yeah, because I need the space. I'm going to open the collar, but I'm not going to take this off. I'm going to just leave it hanging like this, right? So now your job is basically holding the head so that I'm unable to lift the head with the laryngoscope up off the stretcher. Everybody see that? And just this forearm, I need this mandible to be mobile. Very good, right? And then what we're gonna do is, Rita, you're gonna be my another partner. You're gonna come here, right? And you got the, right, the you got the ET tube, and you're gonna put the, right, syringe, excellent, right? So what I'm gonna do is, I showed you, right? Actually, let me get, it was a number 3 here somewhere. I think a 3. Yeah. right? So what you're gonna do is middle finger, right? Maxilla, and then thumb, the mandible, cross finger technique, right? This technique opens the mouth, right? So here and here, I open the mouth. And then I'm gonna come from the side, and my goal is basically just to start to inch. And what I'm looking for is I wanna just see, right, the sliver of the epiglottis. When I see it, I'm gonna insert into the molecular space, right? And I'm not gonna get an optimal view, yeah? You don't have to do that just yet. Yeah, we're gonna do this once it's inside, right? I'm gonna show you, right, you wanna be careful. I'm gonna show you, I'm gonna go specifically into the esophagus, right? So this can go all the way down, right? But what we wanna do, we said we want it to be right in the trachea, and we're gonna get hold up. How do I know I have hold up? It's not letting me advance any further. So I got hold up here. It's not letting me go forward. And then my partner is gonna go ahead and introduce the ET2. Yeah, keep going. And then at this point, I'm gonna grab over. I meet resistance, right? Hold the top of the bougie. I'm gonna rotate it, and I'm gonna advance it forward. Once I see it go past, right, my vocal cords, I'm gonna go ahead and inflate yeah, go ahead. That's all right. So I saw it go through, right? And now what I'm gonna do is when I take out my bougie, I'm gonna do it anatomically towards the feet, right? And what you need to put is the capnography, right? It might be in the in the ET2 kit, right?
It might be.
If it's not in this one, it might be in the one on the over there.
We'll start here, just to get a breath in. It's important.
Right? So the reason why I keep my blade in is I want to make sure, right, when I pulled out the bougie, I did not pull out the tube with it, right? So I see it's in, right? What I do is I hold it. I'm going to note it's barking, right? So this should be 3 times the diameter. This is a little too shallow for this person, right? This was 8.5, right? So I would want it go deeper, right? So maybe 22 at the lip line, right? And then what I'm going to do is once he starts to ventilate, I want to first, right, get my objective data, 45, 35, right, or whatever the number may be. Maybe it's low, right? But this is my objective data, right? And you see, right, you see expansion. So I'm using so you have your stethoscope leader, right? Where's the best place to auscultate?
The stomach.
And not the stomach. I never auscultate the stomach. You know why? Because I saw it go through the vocal cords. So what is the best places to auscultate? Mid-axillary. Mid-axillary. Why is this mid-axillary important?
Because of the location?
Huh?
That's where the lungs are.
Flush between
So it's not per se of the flesh. What if I put it too deep? I put let's say at 27 mark. Centimeters at 27. What do you think is going to happen?
It went to the right.
Excellent, James, right? James says right. So if I'm going to listen to the right side, I'm going to have positive long sounds. I listen to the left, I'm going to have negative long sounds or no sounds, right? Should I be doing right away meal decompression?
No.
No, right?
You should be
pulling back
on it.
3 times the diameter of the tube, right? So very good. So auscultate, this is my subjective data. And then I'm going to look at my pulse ox, right? I want it to read as high as possible or whatever the number may be, right? So the objective data is end-tidal CO2 and pulse ox. Subjective data is what? You seeing it go through the vocal cords and auscultation of the lung sounds, right? But once we have established this, right? So you go ahead and ventilate it, right? And I'm going to take this from you. This is the bite block. James, you're still holding.
And I'm not letting go.
So this is the bite block. One thing I see you guys doing, you guys placing it like this. Don't place it like that. Why? Because if I want to suction, I want this opening be towards the feet. Why do I want it towards the feet? Because then I could put a yank hour if I need to open the mouth, right? Make sense? So the bite block, right, is there. Right. We're gonna put this behind his neck. And don't do this first. We want to get the Velcro going, because if I do this and then I start to adjust the Velcro, I'm going to have problems, right? I may pull it to the left or to the right. So the Velcros is the first thing to be secured.
That's going to be behind the skin collar?
Yep. And then I want to make sure, right, my Velcro is completely secured. James, you're just doing a good job, right? Then this is the lusting. The bolt is the lusting, right? Once I secured, I verify, right, my lung sounds, I verify my end-tidal CO2, I verify my pulse oximeter, right? Once all this is done, right, my tube is verified, I'm gonna say, all right, now it's time to resecure my collar, right? All right, so now once the collar is secured, James, you can let go, right? So just slightly, let me put it a little. So once the collar is on, then you could let go. To be honest with you, when we do cardiac arrest management in the field, right, even if they don't have cervical spine injury, once I intubate, I put a collar on them. Do you know why?
Because you don't want the neck to move and the tube to be displaced.
Displaced, excellent, right? And then what I do is, right, let's say we noted, let's say it was 2021 at the lip line. When the firefighters or whoever brings the patient down, right, I look again, where's my lip line? And then I recheck all the objective data. End-tidal CO2, pulse oximeter, lung sounds, everything. I recheck everything. The moment one thing doesn't look good, I gotta go back and verify if everything is in the right place. I would get somebody holding the C-spine, open this up, get my laryngoscope in, make sure it's in the right place. So I verify before I start my transport. You wanna make sure everything is in place, right? You guys have any questions about anything? Right, clear, right? So his job, you saw, right, holding the earmuff technique, he doesn't let go until the collar is back on, right? If you, I kind of did the procedure quite fast, right? I just want to show you something while we're here. You could keep recording, right? If we needed to pre-oxygenate the patient, I said like we started this off already intubating. This is going to be quite difficult to do. Right? So the technique, right, for pre-oxygenation, remember I was showing you the triple airway usually, but can we do this? We cannot because the cervical is fine, right? So we can only do the jaw lift. So I'm going to show you a technique, right? So the technique is this, right? Connect the BVM. So if I was going to pre-oxygenate, I'm going to say squeeze on 6, right? And you're going to see what I'm going to do. 2 1,000, 3 1,000, 4 1,000, 5 1,000, 6. 2 1,000, 3 1,000, 4 1,000, 5 1,000, 6. 2 1,000, 3 1,000, 4 1,000, 5 1,000, 6. Right? So you notice on 5 I engage, on 6 he squeezes, then I relax, because if you keep this position, your fingers are gonna tire, right? Yeah, you're not gonna, so you relax. Why do I start counting at 2? Because the breath is delivered over a second, right? So 2 1,000, 3 1,000, 4 1,000, 5 1,000, 6. 2 1,000, 3 1,000. So breath is delivered over a second, so I don't count 1. On 5 you engage, on 6 he delivers the breath. I would do this to pre-oxygenate my patient before I intubate if I needed to, right, to get the sets up, and I have the time frame to do it. Do I need someone doing the earmuff right now? No, I'm here, I am stabilizing, I'm engaging, but the moment we pre-oxygenate it and everything is set up, then I'll say, okay, James, come over here, right, grab the ears, right, and then we go with our procedure forward, right? So actually start the procedure this way so that you have practice with that, and then we're gonna intubate. So start with pre-oxygenation first, and then we're gonna do the earmuff, intubate, secure, verify.
Gotcha.
Okay.
All right?